So for this video, we're going to review a little bit about the purpose of using IV therapy with our patients, some of the complications we might come across when we are assessing a peripheral IV, which is inserted in the arms, a few different types of IV solutions. Then we will go through setting up a primary line, giving an IV push both through a line and just through the J loop, this is our J loop. Setting up an IV piggyback with a primary line, and then an IV push just straight through the J loop. And then discontinuing our fluids to convert it to a saline lock. The purpose of the IV therapy could be for replacing fluids, electrolytes, vitamins, of course, delivering different types of medications, antibiotics, and treatments, maybe for autoimmune diseases or chemotherapy type things. 90 to 95% of our patients in the inpatient setting are going to have IV therapy throughout sometime during their visit. And the reason we would choose to go with an IV therapy is because we can give them up to 100% bioavailability of the medication when it's going directly intravenous versus having to go through the process of going through the digestive system, where they might only get 60 or 80%. Okay, complications. So some things that we are looking for when we're assessing our patient. If we have IV lines, we want to make sure that it's connected up to the proper line. So we want to trace from our point of insertion back to make sure it's going where it needs to go. There's all kinds of stories out there of, for whatever reason, usually it's due to severe exhaustion of a nurse, or maybe a patient accidentally switching their lines around, being connected to the wrong thing. They could be getting the wrong medication to the wrong area, so on and so forth. So we always want to trace from our line back to make sure it's going to the right spot. And then also if lines are disconnected. So if we have a line that is disconnected, and it doesn't have a cap on the end of the line, we would need to say it's like this, just disconnected, laying in the bed, or it fell on the floor. We're not going to use the line, okay? We would have to get a whole new setup because we don't want to set our patient up for infection. There's also what we call phlebitis. So if we look, phlebitis, it'll kind of feel like a cord, usually warm to the touch. So what we would do is we could put a warm compress over that, and of course we would DC our IV. We wouldn't continue to use it. If there's an infiltration, that's where the IV dislodges from the actual vein, and the fluid starts to spill out into the soft tissue around the vein. Usually causes a little bit of a bubbling or swelling appearance. There might be a little bit of redness, not always. So we can elevate the extremity. We could put a cool or a warm compress depending on whether there was medication that was infiltrated into the area. Of course, we would DC that line and not use it. And then the other one is extravasation, which is when a vesicant medication, a vesicant is something that's irritating to the veins, essentially infiltrates, but it can open up or it can become necrotic. So there will be swelling, pain, stinging, burning at the site, and there are usually different regimens for treating those. So that's something you would want to follow your facility policy for. A lot of times it has to do with chemotherapies and autoimmune medications. Levophed, I believe, is another one that can cause it. So that's why some of these medications we will use through the central line versus a peripheral. And we will go over central line in the next video. right, so for our IV assessment, it should tell us in the chart where we're at, but also we get it in report, and then when we assess our patient, we know where our IV site is. So we're gonna say this is in our right forearm. It's a 22 gauge. It was just placed today at 10 a.m. We would want to note any redness, swelling, oozing from the site, whether it's blood, whether it's something that could be significant for an infection. We don't want to have any, we don't want to have a bunch of edema. We don't want to see erythema. The dressing should be dry, clean, and intact. Noting again when the date that it was placed. A lot of facilities, 72 to 96 hours is the duration before you need to switch, but follow whatever your facility's policy is. So I don't notice anything out of the normal as far as appearance. And when I palpate, I don't feel any warmth, and the patient's not complaining of any pain or tenderness at that area. Okay, so the next part would be flushing the IV. You always want to have your gloves on when you're accessing your line here. You need your swabs, you need a flush, okay? So if you look closely, there are two different kinds of connectors that you'll see. More than likely you're going to see this one. And this is a lure lock connector. This is a complex connector, and it's also a positive pressure one. So for this one, we don't need any special attachment to our syringe when we flush. You always want to make sure you get your bubbles out. No air bubbles being given to the patient. We want to scrub the hub for 15 seconds. So you need to say your ABCs twice or happy birthday. The 15 seconds is absolutely necessary. Okay, so we did a 15-second scrub. We allow it to dry. And then this just screws on here. I can undo my lock here. I'm going to aspirate to look for blood return, and you may or may not get it. After about 24 hours with a peripheral IV, you might not get blood return, but we want to check for patency, so we should be able to flush it without any problem. Okay, so we flushed. He's not complaining of any pain or tenderness. We don't see any signs of phlebitis. We don't see any infiltration while we were flushing. Okay. Then this would go into your sharps container. Right. The other type of connector, that's a lower lock. The other type of connector that you'll see is a simple connector. So see, it looks like it's got that gummy gel on the top. This is a simple connector, and it could be placed on the J-loop, it could be on the tubing, but in order to access a simple connector, which is a negative pressure, we would need a blunt cannula, which usually says on the package, blunt cannula. Now, and remember, we're going to peel it like a banana. Get your bubble all the way out. Again, cleaning for 15 seconds and then allowing it to dry. And then you're going to take the cannula and stab into the center of it. And then you could aspirate for blood return and flush on your J-loop. Okay. And we'll go over more with the simple connector when I show the CVAD stuff in a little bit. We're going to focus on the lure lock for right now with the peripheral. You'll see both. Your totes usually have the simple connectors, but you may have the lure lock in them. And the clinical setting, you'll see more than likely the lure lock, but some facilities still use the simple connector. So you'll see both out there. Okay, so we got through that. We went through assessment. We just went through our types of connectors. Your IV solutions, so more than likely you're going to be administering crystalloids, which are fluids that replace fluids and electrolytes. They can have additives in it. Maybe we add potassium to it. Maybe there's a dextrose solution. There's hypertonic, there's hypotonic, and there's isotonic. So the hypertonic is going to help draw and retain fluid in the circulation. It's going to increase blood volume, and it's higher concentrations of electrolytes than body plasma. So an example would be dextrose 5% normal saline, or dextrose 5% half normal saline. For hypotonic is going to allow water to shift out of the capillaries into the body tissues. It's going to lead to a decrease in blood volume with lower concentration of electrolytes than the body plasma. So dextrose 5% water would be considered a hypotonic. And then the isotonic is the same concentration of blood plasma for electrolyte concentration. Example would be normal saline, which is 0.9% sodium chloride, or lactated ringers. So you'll most likely see those and be able to administer those in the clinical setting as you go through the program. Colloids are the other type of solutions, and those are usually your blood products. So red blood cells, plasma, platelets, and albumin. So you'll probably get the opportunity to watch those, and that's going to help increase the blood volume that you have. They are much more viscous, and there's usually a lot more in the process as far as maybe needing a second nurse to double check you to be able to give those products. Okay, so for a primary line, we have two different types of tubing. There's macro and there's micro. So a macro has 10 drops per milliliter, and a micro has 60 drops per milliliter. So you always look in the top left usually, and it'll tell you how many drops per milliliter on your tubing. So that way when you're doing drip calculations, you know what you're using. Another way to tell the difference, usually with the micro tubing, I don't know if you can see, but it looks like there's a little spike there in the middle. But that's what the micro tubing has. The macro tubing doesn't have that. Your totes come with the macro tubing, so that's what I'm going to demo. Of course, we would want to look at our packaging, making sure that it's not expired, that it's not opened, that there's no tears or anything, there's no moisture. There's usually a little perforated edge. You just pull it on the side and you can take this out. You would want to make sure that the connectors are on there, because if they're not, you would get a new set of tubing. Then you want a roller clamp. So see, there's this wider part down here means that it's open all the way. And if we snug it up, that means that it's closed. You want it closed before you go to spike your bag. Again, we have the lure lock here that we're going to use with this one. We have our order, which is for normal saline. Let's say that we are going to do, this is 1 liter, and we're going to do it over 10 hours. So when we program our pump, we're going to do 100 mLs per hour. Now most bags in the clinical setting, actually all of them that are not used, we can hang the bag like this and pull the stopper out and spike and it won't leak. When you're practicing in the lab, we have the golf tees, so you'll have to open the bag upside down, otherwise it's just going to leak. But we need to be sterile to sterile, so I'm going to undo my golf tee. I'm going to take my cap off, and I'm going to use some good pressure to spike my bag. Then I'll invert it. We're looking for clarity of the solution. There shouldn't be any floaties. There shouldn't really be any moisture. Now, sometimes the outside of bags, when they're brand new, might have a little bit of residual moisture, but there shouldn't be any leaks or tears or anything like that with the bag. It shouldn't be expired, and we always want to make sure that it matches up with whatever our order is. The next thing we're going to do is we're going to prime it, and we need it to go all the way to the end and no air bubbles. So we're going to squeeze this chamber. We want it no more than half full because we need to be able to see the drops when we put our pump up. So I've got this all locked. I've primed my chamber, and I'm going to slowly unroll. And I want to make sure that I don't have any bubbles as this goes through. Sometimes you have to tap a little, get the bubbles out. Now, just so you know, when you're practicing, you're probably going to have more bubbles with each time that you practice because these are single use in the clinical setting. You can prime into a sink or a trash can. In the med room usually is where I would hang it. All right, so we've got this fully primed. I have no bubbles in the tubing. It looks good. I'm going to label my tubing with the date, time, and initials so that everybody knows when I put the tubing up. I'm also going to label my bag with the date, time, initials. Depending on your facility, they might want your patient's ID sticker on there too. So just be mindful of that. Next thing I'm going to do is I'm going to go to my pump, and I'm going to weave it through my pump and set my pump. Then I'll hook it up to my patient. Okay, so for this, these are the Baxters. They're a very basic pump. In the area, we don't see them too often. They are still out there in use throughout the country. And with all the pandemic stuff, it's a possibility that maybe you'll see it. But for this one, we're going to push this lever and open. And then we're going to feed. So I have to make sure that this little safety clamp is pressed down so that I can weave my tubing through. This top port is going to be for your piggybacks, so it always has to be above the pump. So I'm going to start down here, and I'm going to insert my blue clip in here, right below where it says safety clamp. I'm going to weave this up and around, and then I can close my door and push it shut. And the next step, I'm going to turn the pump on. And I'm going to be doing a primary, so I'm going to hit prime rate. I said I was going to do 100 mLs per hour, so that's going to go on the top. My VTBI is the volume to be infused, and we said that that was 1,000. Okay, so 100 mLs per hour for a volume of 1,000 milliliters. So my pump is now set. My flush. So I, of course, got his identifiers. I had my order. I have my pump set up, identified whether there's any allergies. I assessed my site, and I don't notice any redness, swelling, phlebitis, infiltration. And I'm going to flush just to make sure that there's no infiltration or pain. Scrubbing for 15 seconds. And allowing it to dry. Okay. Aspirate for blood return and I flush. He denies any complaints of pain. We're good there. Gonna take a second swab. This I will put in sharps when I'm done. And I'm gonna scrub again. We scrub in between each time that we would reconnect a syringe or to attach the line. So another 15-second scrub. If you want to close the clamp in between, you can. With a peripheral and with the negative pressures, you don't necessarily have to right then and there. If you want to, it's additional safety. But typically with the peripherals, just connect, flush, re-scrub, and connect our line. We go make sure that the clamp is open. Okay. Both clamps are open here. And now I can hit primary start. And I should see drops coming in the chamber. So you always want to make sure you have drops before you leave the room. You assess throughout to make sure that the patient's not having any complaints of pain, watching for any signs of infiltration, phlebitis. He said he's good. He's tolerating it. This is normal saline that's running. And that's pretty much it with that as far as a primary, setting up a primary. To shut this off, we can hit stop, and that's going to pause, and then we hit on off to turn the pump off. Okay, so we got that. The next thing would be delivering an IV bolus, which is an IV push through an existing line. And we will always want to check compatibilities. So we're going to give the patient some ondansetron, which is Zofran. We're using it for nausea or vomiting. We say that he does have an abdominal surgical wound, and he does have some nausea. So he had pain medicine a little bit ago. Now he's having some nausea. This is 2 milligrams per milliliter, and the order's for 4 milligrams. So we're going to give a total of 2 milliliters. We're going to give it right through our line here. So of course we would do our 3 checks, which we're looking at the name of the medication, the dosage, and also expiration date. We check that 3 times, once when we're taking it out of the Pyxis, the second when we are either drawing it up, and the third one when we're at the patient's bedside. So I'm going to say I'm in the med room. I did 1 med check, and I do the second med check while I draw it up. If I'm preparing it outside of the patient's bedside, I need to make sure that I label it. Scrubbing 15 seconds on the vial. Now for a push straight through this line, if it is compatible, I do not need to flush before or after. If it's incompatible, we'll talk about that in a second. Okay. So I prepared my 2 milliliters and I have labeled it. And I'm going to go to his room, get his name and date of birth, allergies, any pre-assessments for Zofran. He's complaining of nausea. This is an as-needed medication. He can have it every 6 hours as needed. Some side effects that you could experience with the Zofran, maybe constipation at some point could potentially become a problem, so you'd want to assess for that. Could make you a little bit drowsy, just so that you are aware, because of the nature of the medication. So we did that. We have our third check. We would scan our vial. We've scanned his wristband. Everything matches up there. We're going to take our port that's closest to the patient, and this is where we're going to administer our medication. So we have our pump flowing. And I've looked at compatibility. It is compatible with normal saline. So I know that I can go right through my line, and I'm going to use a kink and release in order to administer it. I know that I need to administer this medication over a 2-minute time frame by looking it up. So you always want to look up your push times on your meds so that you don't cause your patient any issues. And also whether or not it needs to be diluted. Most medications now are already pre-diluted, but some might need to be further diluted. So take a look at that, and then also look at your packaging for your medication, because that'll instruct you as to whether you need to dilute or not. So you did 15 seconds, let it dry, and I'm attaching the medication. I selected a 3 ml syringe for this because I only need 2 mLs. Smaller syringes allow you for a way more accurate dose than the 10 mLs. So for this, I'm going to crimp right here, and I said I need to do this over 2 minutes. So for the first 15 seconds, I am going to push a 0.5 milliliter. And then I'm going to release it to allow the IV fluid to flush it through. I'm going to crimp it again, push another 0.5 ml over 15 seconds. And the pump will beep because it's sensing that the line is occluded. So just be aware of that. When I unpinch it, it'll usually go through. And it's flowing through with the fluids now, so it's flushing in the med I just gave. And then I'll push another 0.5 ml over 15 seconds. And then I will release to let the fluids carry it in. And after that 15 seconds, I will do the last 0.5 ml over 15 seconds, and then allow the fluid to flush in. So I didn't need to flush before or after this because I'm using the line as my flush. That's good for compatibilities. If for some reason the medication is not compatible with your fluids, you want to stop your fluids. You're going to flush with normal saline first, then you're going to do your medication, then you're going to flush with an additional saline, and then you could restart your fluids. Or if for some reason maybe the medication is only compatible with dextrose, D5. Maybe I do a D5 flush, the med, and then the D5. So that's knowing what your medications are compatible with. Okay. The next is going to be the IV piggyback. And so the IV piggyback is going to be administered just like a piggyback ride, right? So we're going to use this port that's at the top above the machine is going to be where we put our piggyback, okay? We never use these bottom 2 ports for piggyback, only this one. For your piggyback, you'll use secondary tubing. Again, you can see the 10 milliliters per ml for this, so it's a macro tubing. And look how short this tubing is. So you're not ever going to connect this without a pump. It's not going to be safe. It's not going to reach your patient properly, and the medication's not going to go in properly with the pump. So we're always going to connect it up here, And you always have a little hanger because the primary fluid is going to hang lower than your piggyback, which is usually going to be like an antibiotic. And then some other types of medications sometimes. Let me see an example. In palliative medicine, we would dilute 50 milligrams of Benadryl in like a 25 ml bag. Or we would give some of the kind of sedating medications diluted, and then we would have that slowly piggyback. So we had better control of the time on that. So we will say that we have an order for vancomycin for Mr. Walking Feather here. Again, we're looking at the same thing. We want to look for clarity, expiration date, any signs that there's ill integrity, rips, tears, leaks, anything like that. We wouldn't want to administer this. We want to know the rate at which to infuse it, so we can look that up in our books. Sometimes it's listed in the MAR for 1 gram of Vanco. This is 200 mLs, and we have the option to run it over 60 to 120 minutes in the drug book. So I'm going to choose to run this over 60 minutes. So I'm going to do 200 mLs per hour when I program it into my pump with a volume of 200 mLs. So I'm getting this all set up. I got my supplies and I'm going into his room. I get Mr. Walking Feather's name and date of birth, check for allergies. He doesn't have any, ask if he's ever had vancomycin. And he said yes, this is his 3rd dose. So something to keep in mind is some medications we need to check labs for. For vancomycin, we usually look at a peak and trough level before we give the 4th dose to make sure that it's not causing too many issues. This medication in particular is nephrotoxic, so it can affect the kidneys. We also want to look at the BUN, blood urea nitrogen, and the creatinine levels to make sure that it's not causing damage to the kidneys. So we would give this every 12 hours is what it's ordered for. It's not expired. Again, I pulled my stopper out of there. I'm going sterile to sterile, and I have my clamp closed because if I invert it, I am going to have it leak everywhere. So with a piggyback, you can actually prime your line a little bit differently, and this is going to help reduce having any medication leak. So what I'm going to do is I'm going to lower my saline. Of course, we did our 3 med checks and all that. I have my pump stopped for right now. I'll hang that up there for a second. See, I didn't prime my line at all because I'm going to back prime here. So I'm going to clean for 15 seconds and then I'll allow it to dry. Again, we check compatibilities with these medications. If an antibiotic or whatever is not compatible with your solution, you're going to use just a regular primary line to run that medication. Piggyback lines are only if it's compatible with whatever your solution is that you have hanging. So I do 15-second scrub, allow it to dry, and then I am screwing that onto your lure lock. And then to back prime, all I need to do is gently lower so that the tubing fills up. And you'll see there's bubbles going into the bag, and that's fine. And then you see fluid filling up in the chamber. So again, no more than halfway. Okay, I can roller clamp it closed until I get it where I need it to go. This tubing would also have the date, time, and initials on it. I'm going to reopen this clamp because otherwise, if this remains clamped, the primary is going to run and they're not going to get any of their antibiotic. I'm going to turn my pump back on. I still have my primary at 100 mLs per hour and the volume, they'll get 1 liter over 10 hours. Now I'm going to go to secondary rate and this is going to be for the vancomycin. And I said we were going to do 200 mLs over 1 hour, 60 minutes. So I have 200 mLs per hour in the first one. Then my volume to be infused, VTBI, is 200, which is the whole bag. I make sure everything is nice and unclamped, and it is. And then I'm going to hit secondary start. And what I should see is drops up here in this chamber. And this will continue until they get there, until whatever's programmed in there runs out. Then, once it's done, the primary bag will resume dripping automatically by itself, as long as you've got your pump programmed. Okay. All right. So what do we do? Say we're going to discontinue our fluids, convert it to a saline lock, and then I'll show you the IV push through just a J loop. As far as converting to a saline lock that's just leaving the J loop in with nothing else, you don't really need to do anything special. Usually all of this is going to come down and we dispose of it per policy. I'm just going to put a cap on the end of it here. Okay. So for this one, I disconnected my line. I'm scrubbing for 15 seconds. And then I'm just going to flush. Make sure we get all of our bubbles out. Now be mindful, if this drops, I need to clean it again. So if I drop it, I have to clean it again with a new swab. So we did our 15 seconds. I'm going to connect, and I'm just going to flush. Depending on facility, could be 3 to 5 mLs, 2 to 10, just depends on what they put in. And then I'm going to clamp and unlock, and this will go into the sharps container. That's converting to a saline lock, and then doing IV push through the saline. Let's use our example again of the Zofran, except now he's off of his fluids. We're going to go through the J loop. So we scrub for 15 seconds. We've done our 3 checks. We've gotten our identifiers. We've scanned his band. We've scanned the medication. He already knows about this medication because he's had it already. And I'm going to go in and we will do our flush first and then our med. So 15 seconds of cleansing. Let it dry. I'm going to aspirate for blood return. Like I said, after 24 hours, you might not get blood return on a peripheral. I'm going to flush with, say, 2 to 5. This is going to go in the sharps. I am going to get a new swab and clean for 15 seconds. And allow that to dry. And then I know that I need to do 2 minutes for my Zofran. So I'm going to do 15 seconds with my watch. for a half ml for 15 seconds. Okay, so after 30 seconds, I've put in 1 ml of the 2. I'm sorry, I'm saying 15 seconds. I mean 30 seconds per half ml. Oh my goodness. So after 2 minutes, the full. So 2 minutes total for all of the Zofran. So 30 seconds per half ml. Clean for 15 seconds again. And then we will attach the flush. And we need to push the flush at the same rate as the medication. So about 30 seconds per half ml. Okay. So it's been, say, 2 minutes, and we've chased that 2 mLs of the Zofran. I'm going to continue to slowly flush to a total of 5 mLs to make sure that the medicine gets all through the J loop, and then I'm going to just clamp and disconnect. So that is your push through a saline lock. And I believe that is it for that. Continue to assess your patient. Just as a kind of a word of advice from a lot of seasoned nurses. So when they come on shift, a lot of times what we do is when we go in to first see our patients and take a look, we like to take our flushes and our alcohol swabs in and check our IV to make sure that it's patent before we get started with med pass. Because if we lose an IV, we can try to get one in. Whereas if we're in the middle of med pass and then we determine that we have an IV that's lost, sometimes medications are very time sensitive and they have to be hung within a certain amount of time, or maybe they're refrigerated, so on and so forth. So checking patency right off the rip is something that's pretty helpful at the beginning of the shift. That's it for this one. Watch the CVAD one next.